at the 25th minute or so of the program, I succeeded in creating some debate, so I'm kind of, very happy about that. So here, what we just heard, Riad, is like, a little bit of that collusion pushing some of the BCLCC into early start in B with systemic therapy because of the concern from, a medical oncologist view. What about what we hear about probably the application of the local therapies into more BCLCC patients?
Yeah, so in reality, I don't know that it's that much of a debate. We actually agree. We think there is a healthy sort of medium and healthy balance between the local regional therapy and the systemic chemotherapy. We agree that we want to be cautious to make sure that we perform treatment selectively and maintain liver function. We agree that we want to make sure to start systemic therapy early and not wait for progression. In fact, this is work that we did years ago showing that you in fact want to start systemic therapy soon after a local regional therapy, not wait for progression. Because if you wait for progression, then half of those patients have decompensated liver disease, and we study this in fine detail. So I actually agree with that. I believe in using local regional therapy and then early use of systemic therapy. This is part of the individualization. This is part of experience. It's not explicitly stated in guidelines, but we are on our, at least at Northwestern, on our 1,000th HCC patient coming up this week, treated with Y90. So I think, and other local regional therapies. So I think we have pretty much figured out that, again, like Richard was saying, early use of systemic therapies is really the way to go after 1 or 2 rounds of local regional therapy. So we agree.
And do you think there is a potential for or interest in seeing a local therapy applied in a systemic situation, maybe in combination with systemic therapy?
Yeah, so that's a great question. So one of the areas that has been really traditionally developed and considered a niche application for Y90 is the BCLCC patient that has portal vein thrombosis, BCLCC because of the PVT. And because of what Laura was saying in terms of the microembolic effect, you can use yttrium-90 as a cytotoxic without risk of ischemic hepatitis. And we do believe in the sort of early adjuvant use of something like sorafenib, and some of our best results are like this. We've got some patients converted to surgery. So people really are pushing these sorts of concepts. So we've seen this, again, with the local regional therapy, particularly yttrium and the use of early sorafenib, and now with the regorafenib data, it'll be interesting to see how we incorporate that. But we've been on that. I've agreed to that for several years. In fact, that's how we've practiced.
And can you tell us a little bit more about, studies like the SARA study and where does it fit?
Yeah, so the SARA study. So there's been a lot of interest, although a lot of difficulty in executing. There's a lot of interest in performing head-to-head studies. It's very difficult to compare a therapy, an intervention with a drug. And the SARA study is a head-to-head analysis comparing Y90 to sorafenib. And the study has enrolled. I believe it'll be reporting this year. We're very excited to see what the results are. Some of the issues that might arise are what the inclusion criteria were, because as we've learned in HCC, clinical trial design is critical, patient selection is critical. There are a lot of negative studies out there, potentially because of incorrect patient selection criteria. But we'll be interested to see how that is. The limitation, I fear, with these head-to-head studies is overall survival as an endpoint will be confounded by crossover and post-treatment progression and post-treatment therapies, such as now regorafenib. So I fear that while the study is robustly performed, that some patients will cross over, some will get regorafenib, and then we'll have to interpret these data. But this is the reality of doing HCC studies.
Very fascinating, actually. If anything, to summarize, local therapy is really took a very, quick improvement in regard to the research development. And we just heard from the world expert in regard to yttrium-90, but same thing applies for TACE and TAE. And obviously, there's a better understanding about where do they apply and what's the value in regard to, their benefit for patients. Nonetheless, it remains a kind of rather debatable field because of the advancement or rapid advancement in regard to the different technologies and those where each one of them might fit at the end of the day. Nonetheless, we probably all agree, and we just stated it, that passing the information to the patient and consult early in the game with a interventional radiologist is very critical to ensure that they have the applicable local therapy as deemed necessary. We also heard about kind of, that kind of, what we talk about in the academic world about the collusion between the local and systemic therapy. But you probably kind of noticed, as much as I tried to create a debate over here, but there is a clear agreement that probably at the end of the day it's going to be more of a marriage rather than a kind of, separation of the two therapies.